All right, everyone, good evening to all of you. Let us begin with today's discussion on another set of important topics that we have from pediatrics. So I'm Dr. Kavitha, your pediatric educator. And now we're going to start discussing about some of the important concepts related to acyanotic congenital heart diseases. So let us switch on to the first question from ACHT. Okay, so again, very, very important to know that we have to be very sure about reading the question, be very patient about the options, and definitely try to understand what the question is asking and then put down the responses. So please start typing in your response in the chat box, all those who are listening to the class. So the first question is, okay, so the first question mentions about the acyanotic congenital heart disease. Okay, so the question asks, all of the following are acyanotic congenital heart diseases except. So we all know as the broad classification, we have got acyanotic and also the cyanotic heart diseases. So which of the following is not a congenital acyanotic heart disease? Okay, so the options over here mentions the first option is AST, VST and PDA. The second option is AV canal defects. The third option is tetralogy of Fallot. Fourth is malformations. Then we have coarctation of aorta, aortic stenosis, and also pulmonary stenosis. So broadly, we have got acyanotic and cyanotic congenital heart diseases. So all those disorders in which cyanosis is present, that means the baby turns out to be cyanotic or blue. Those are the cyanotic heart disease. Apart from that, all the other disorders are acyanotic heart disease. All right, so which is not a acyanotic congenital heart disease? Okay, so Preeti has answered as option number C and G. Okay, so that is right. Option number C, tetralogy of Fallot, is not a acyanotic congenital heart disease. It is a well-known condition where it presents classically with cyanosis. So TOF is a cyanotic heart disease. But regarding option number G, why do you think it's a cyanotic heart disease? Whenever there is pulmonary stenosis, what basically happens? The pulmonary valve gets stenosed. That means the blood flow through the pulmonary channel is going to be diminished. But isolated pulmonary stenosis is not a cyanotic heart disease. It becomes cyanotic only when the heart has got certain channels which can allow mixing of blood. So if TOF is there, that means it has pulmonary stenosis along with VST. Then what will happen? There is some amount of mixing from the right to the left chamber. That is why cyanosis is present. But if it is isolated pulmonary stenosis, then it is going to be acyanotic congenital heart disease. Is it clear to all of you? So acyanotic CHTs are most common types where we have so many classical defects where mixing of blood does not happen, or it presents with left to right shunt. That means there is overload in the right side of the heart, because whenever the shunt goes towards the left side, there is going to be mixing of the blood and cyanosis, which falls under the category of cyanotic heart disease. All right. Okay, question number 2. Okay, next question mentions the types of AST includes which of the following. So AST is one of the most common defects that is seen inside acyanotic congenital heart disease. Apart from that, VST is instead the most common, which is seen incidence wise. But apart from VST, we also have very, very important topic, AST. Now, AST has got many subtypes. So can you answer the types of AST? Is it fossa ovalis AST? Sinus venosus AST, ostium primum AST, coronary sinus, inlet AST, or AST which has got an autosomal dominant inheritance known as Holt-Oram syndrome. So which are the types of AST? Okay, Shiva has answered as option B, C and D. All right, isn't fossa ovalis AST a type of AST? Definitely B, C and D are correct options. But apart from that, fossa ovalis AST is also a type of AST. Okay. So that falls under a very important category of types of AST. And Holt-Oram syndrome, not to forget, it's a very commonly asked question in your exam. Okay, Nitya has answered it as A, B, C, D and F. That is absolutely right. So inlet AST is nothing. It is basically the inlet VST which has been given as an option to confuse you. So ASTs are nothing to do with inlet and outlet tract. Those are the classifications which are used for VST. So please don't forget Holt-Oram syndrome. It's a very, very important syndrome that is associated with AST and it has got autosomal dominant inheritance. Can anybody mention in the chat box what is the classical feature of Holt-Oram syndrome? AST associated with what is equal to Holt-Oram syndrome? How do you recognize Holt-Oram syndrome? Anything very, very specific to it? Okay, anyone? So it has got a defect in the thumb part of the child. So please read about Holt-Oram syndrome. It is very, very important. Simple one-liner MCQs which can come in the exam. So AST associated with radius deformities and AST is associated with absence of thumb. So that is basically Holt-Oram syndrome. Is it clear to all of you? So let's move on to question number 3. Okay, next question mentions clinical features of AST. So if a child has got atrioseptal defect, how will the child present? So please type in your answers. Clinical features of AST includes. Anybody would like to answer? Okay, let us see the options. So first option mentions failure to thrive in childhood. Now, whenever there's a heart defect, what basically happens, there is going to be certain amount of overload on the heart. So the overall function capacity of the heart is going to get diminished. Plus, whenever there is left to right shunt, what happens? The right side of the heart gets overloaded. So that can result into overload symptoms inside the lungs, which will result into an onset of LRTIs. So frequent infections can happen in these children who have got VST and AST. Although failure to thrive is a classical feature of VST, it can be seen to some extent in patients of AST also, depending on the size of the defect. So we cannot exclude that failure to thrive is not seen in AST. It is seen in types of AST, especially when the size of the defect is very, very large. So first option is a classical clinical feature. The second option mentions mild precordial bulge. So this mild precordial bulge is going to happen. Why? Because whenever there's a shunt defect, what happens? The shunt allows the flow of blood from one side of the heart to the other. So the other side of the heart is going to get overloaded. So that will present as a precordial bulge because of a particular hypertrophy of a side of the heart. So in left to right shunt, the right side of the heart is going to get hypertrophied. So that will present as a precordial bulge. The third option is right ventricular systolic lift, which is palpable. So definitely it's a left to right shunt. So what will happen? And when there is a left to right shunt, there's right overload of the heart. So whenever you will examine a child with AST, so on right side of the heart, we can feel a systolic lift, which is easily palpable. The fourth option is pulmonic ejection click that is present. Yes, that is absolutely right. It is a classical sound that is heard in AST patients, and different sounds are heard in different types of pathologies in the heart. So once we understand the concept of the type of shunt that is present, the flow of blood that is present, then we'll be able to better understand the importance of sounds and murmurs in cardiology. So pulmonic ejection click is present. Why? Because there is right-sided overload in the heart due to left to right shunt. So suddenly when the too much of blood from right side of the heart gets pumped out in the pulmonary tract, it results into this type of sound. Pansystolic murmur, no, pansystolic murmur is not seen in AST. It is a classical feature of VST because that causes left ventricular hypertrophy. It causes left ventricle overload symptoms. So these are the important features which are seen in AST. So next question. Okay, so question number 4 mentions how do we diagnose AST? So how can we diagnose AST? Anybody would like to answer? Preeti, Nitya, Shiva. Diagnosis of AST includes which of the following? So it's very simple to diagnose these shunt defects. It can be diagnosed by multiple ways. So please put down your responses. Chest X-ray, ECG, 2D echo, catheterization, angioplasty. Which methods can be used to diagnose AST? Okay, Preeti has answered A, B, C. Okay, Nitya has answered A and B. Okay, B and C, all mixed responses. So A, B, C, D, all of them are correct response. So on chest X-ray, we can easily see the side of the heart which is getting hypertrophied. We have got classical signs which are present on the chest X-ray, which can help us to make a diagnosis. So if we see an AST patient, we'll see that the right side of the heart is overloaded, and we can see dilatation of the right atrium because the main shunt is present in the upper part of the heart. ECG, again, very, very diagnostic because again, we can see the right atrial hypertrophy. It can also have a right ventricular hypertrophy. So that is going to present with ultimately symptoms of right-sided deviation on ECG. 2D echo is the classical test that we use for diagnosis of all the important cardiology symptoms and diseases. So 2D echo can help us to easily visualize the shunt. We can see the pressure changes. We can see the hypertrophy of the chambers. And then cardiac catheterization. Please do not forget, although cardiac catheterization is not recommended in every case because it is an invasive procedure, but it is the diagnostic procedure of choice for any cardiac disease in pediatrics. Why? Because when we do a cardiac catheterization, we can easily visualize the defect which is actually present. We can measure the changes in the pressure in each chamber of the heart, the changes in the SpO2 levels, the amount of mixing of blood that is present, and the actual anatomy of the structures that is causing the defect. So it is not always like a simple diagram that we see in the book that a shunt is present here and the moving of the blood from left to right or right to left is happening. There might be many other additional vessels and additional channels which can develop over due course of time because of changes in the pressure. So cardiac catheterization is always advised before a surgical correction of the cardiac disease because we want to know that what is exactly the anatomy or what is exactly the problem that is present inside the heart. So all these four are diagnostic procedures for any of the cardiac diseases, be it AST, VSD, TOF, any kind of stenosis. So it is very, very important to do all these tests and then correlate and finally make a diagnosis. Angioplasty is not an investigation for the diagnosis. It is a corrective measure that is done. All right, is it clear to all of you? Can we move to next question? Question number 5. All right. So fifth question mentions about PDA. What is PDA? Patent ductus arteriosus, very, very important topic in pediatrics. Very commonly asked in almost all the exams. So please read the options carefully and put down your response. Anybody would like to respond? Nitya, Shiva, Preeti? What could be the answer to this question? What is PDA? Okay, so Shiva has answered A, C, D, and E. That is absolutely right. So the first option mentions it's a communication between the pulmonary artery and aorta. That is exactly the definition or the basic meaning of PDA. So patent ductus arteriosus. The ductus remains patent despite of the birth because there is a channel that is connecting the pulmonary vasculature to the aorta. So that is the abnormality which is present. Although it is normal in the fetal life, but after delivery, this ductus has to close. So option number B mentions failure of ductus venosus to close within 48 to 96 hours of the postnatal age. So can anybody mention in the chat box what is the exact timing for the closure? And does it happen properly in a term baby or a preterm baby or a post-term baby? Which babies are more prone to develop PDA? Preterm, term or post-term? The third option mentions, yes, usually we say that it should close immediately after birth, but yes, preterm, very good Preeti, that is right. But we can wait maximum till 4th day also. But 48 to 96 hours is not the right option. It should close immediately after birth if the baby is term and the baby has normal vascular structures inside the body. So preterm babies, definitely if they are born before the gestation age, they are more prone to develop patent ductus arteriosus. It is possible that with due course of time and when they reach their corrected gestational age, it can close. But in some babies, it might not close and requires treatment. Okay. Now, how will a child of PDA present? The clinical picture basically consists of heart failure features. So in PDA, what is happening? Again, there is shunting of blood. So shunting of blood is again towards the right side of the heart. Now, basically, this entire blood in the pulmonary channel will go back through the lungs From the lungs, the purified blood will again come back to the left atria and left ventricular. So ultimately, the overload also happens in the left side of the heart. So usually we see the left-sided overload, or we can see biventricular overload. So it is again a shunt defect. Because of the overload symptoms, the baby is going to present with congestive cardiac failure. There is going to be a wide pulse pressure because the difference in the pressure of both the channels is too much. So that is why there is difference in the pulse pressure of the child. Bounding pulses is a very characteristic feature because of difference in the pulse pressure. Undue tachycardia. So usually we see whenever a baby is admitted in NICU and the response to medicines and response to various other neutralization of the environment like RBS monitoring, temperature, does not improve the heart rate of the baby, we usually do a screening for PDA. So undue tachycardia, undue metabolic acidosis, and also undue CO2 retention in the baby. These are all signals towards the diagnosis of PDA. And machinery murmur is very, very classical. Why? Because see, the shunt is very, very huge. It is like a complete vascular structure that is connecting two important channels of the heart, which is the pulmonary and the aorta. So the blood flow is very, very high. So that is why we hear a continuous murmur. In other defects, the shunt is very, very small. It could be maybe 0.5 mm, 1 mm, 2 mm. But here we have a complete channel which is connecting two important huge vessels of the body. So there's a continuous blood flow through the shunt. So we'll hear a machinery murmur. Okay, diagnosis is made by chest X-ray, ECG, and 2D echo. As I mentioned, all the cardiac diagnosis is made by a combination of X-ray, ECG, and echo. Management is basically fluid restriction, yes, because we don't want the baby to go into overload symptoms. IV indomethacin or ibuprofen. So ibuprofen is given orally, which helps in the closure of PDA. If not orally, the response is not seen in certain cases, or babies who are very, very sick cannot take oral intake of ibuprofen. Those who are kept NPU, we can give a trial of IV indomethacin. And surgical closure is the treatment of choice. So PDA closure or patch closure can be done where the shunt is completely destroyed and the normal vascular structure is established. So that is about PDA. So is it clear about important topics from acyanotic congenital heart disease? Please put a thumbs up those who are understanding all the topics. Any doubts anybody has? Okay. So that is very good that you're understanding. See, acyanotic congenital heart disease can have multiple MCQs in the exam. You can be asked from AST, VST, PDA. You can be asked about important cyanotic heart diseases. So you should understand the concept very, very clearly because questions keep changing. But if you know the disorder and how it presents, you can easily answer in the exam. Okay, let's move on to the next important discussion. Okay, sudden jump from one topic to another. So from cardiology, we jump over to pediatric psychiatry. So very important ignored topic from pediatrics. Let's discuss about ADHD. So attention deficit hyperactivity disorder. The first question for ADHD. What are the etiologies related to ADHD? So how is ADHD caused in a child? Is it related to dopamine? Is it related to serotonin? Is it related to maternal factors like stress, smoking, any kind of brain injury to the child, any kind of abnormal dopaminergic, noradrenergic receptors, or BRCA1 gene mutation? So multiple options are correct. Those who have read this topic can easily answer. So please put down your responses in chat box. Nitya, Preeti, Shiva. A, B, and F. Okay, A is absolutely right. Dopamine receptors have a very, very important role. Instead, you can remember ADHD has got too many D's in the name. So dopamine is one of the most important culprit in developing ADHD. B option is also right because it has got serotonin receptors. Okay, if anybody wants to ask a question, you can ask. So that wants to ask something, please unmute yourself and ask the question. You can type in the chat box also. Okay. All right. Apart from that, what are the other important things? Perinatal stress, can it result into ADHD? Can perinatal stress result into ADHD? Yes, it can cause. Smoking is also a well-known factor for ADHD. Traumatic brain injury can also result into disturbance in the balance between various neurotransmitters, and it can cause ADHD. Abnormal central dopaminergic and noradrenergic receptors can also cause ADHD. So dopaminergic receptors and dopamine are very well known. Apart from that, BRCA1 gene mutation has nothing to do with ADHD. These are all behavioral disorders which are associated with either maternal factors or problems in the neurodevelopment of the child. Please ask your question. Or you can type in the chat box whatever doubts that you have. We can discuss it in the end of the session, or if it is relevant to the topic, we can definitely discuss it right now. Alright, so please remember the important factors for ADHD. It is dopamine, serotonin, all the maternal factors, and also any kind of abnormal balance between important neuroreceptors in the brain. Okay, can we move to next question? Question number 2. Features corresponding to the factors that can result into inattention in ADHD includes. So what basically happens in a child who has ADHD? Very, very important topic. Most of us tend to not read this topic in detail. So if you know what happens in ADHD, you can easily imagine a child who has got ADHD. And I always remembered as a joke for my exams that ADHD is what we develop during the exam time. We never focus on the question. We never tend to read towards the end of the statement. We never try to be patient and think over. That means the attention span gets reduced. We always try to do some activity with the hand, like shivering of the hand, shivering of the legs. So these things and stories and this kind of tricks help you to remember such disorders very, very easily. So classical things that happen with you before the exam and with some students during the exam also is basically what is ADHD. So let us see. The first option says fails to give close attention to details and makes careless mistake. Very, very valid to our examination situation. Yes, Preeti has answered A, B, C, E, and F. So let us go through all the important options. So option number A is absolutely right. The next option is difficulty in sustaining attention in tasks or play activities. So very well said, difficulty in sustaining attention. We don't have the patience to read the end of the statement, which mentions all except, all of the following are true except, which is the false statement. So we just read the topic and we are in a rush to answer and make silly mistakes in our exam. So difficulty in sustaining, the importance of sustaining and having a focus or an attention span. So that is lacking in children who have ADHD. The third option mentions does not follow instructions and fails to finish the schoolwork. Now that is absolutely right again. Those who do not follow what is being told by their parents or teachers, and they definitely fail to complete a particular task. So that is a classical feature of ADHD. They always have a flight of idea in the mind. They keep on switching from one particular thought to another thought. Okay. Fourth option mentions difficulty in organizing tasks and activities. Yes, very, very important. Again, we are not able to actually organize anything before the exam. We think let's read neuro it at one go, then we switch on to cardiology, then we switch on to psychiatry. We never organize that for 2 hours I have to read neurology, for 1 hour I have to revise cardiology, for 2 hours I have to revise general pediatrics, and stick to that particular task or activity. So that is all because of the disturbance in the mind that they are constantly having. Option number E mentions avoids to do things that take lot of mental effort for long period of time. So is that right? Is this option right? Does it suit what we do before the exam? Avoids to do things that take a lot of mental effort for long period of time. Now, if somebody tells you to sit down and read entire CNS unit before your exam and revise only neurology, so you will think let's just read 3-4 topics which come in the exam and let's let rest of them go. So if you're given an important task, if an ADHD child is given a task to solve some amount of questions for 1 hour duration, to sit on a sofa and chair and to actually solve those questions in 1 hour duration, so it requires a lot of mental effort for a long period of time. So child is going to refuse, or the child will have a lot of distraction. So that option also classically mentions ADHD. The last option says often has difficulty playing in leisure activities quietly. So that is not right. So whenever before exam, when you're trying to revise and any of your roommate or friends come to your room and say, let's go to the canteen and have some snacks, you're always ready to go to the canteen, right? Nobody refuses. So they love to do leisure activities which do not require a lot of attention span. So ADHD for myself, I remember with my behavior before the exam, and it classically suits to each and every student. I think all of you can correlate ADHD with your anxiety and the kind of disturbance that you have in your mind before the exam. It should not happen during the exam. Before the exam, it's very, very common. Is it clear to all of you? Please put a thumbs up those who understood this topic, because it actually summarizes everything inside this particular situation. Yes, I asked Sudha to please mention your doubt. She had raised a hand. Please type in your doubt in the chat box so you can unmute and ask the doubt. Okay, so please remember ADHD very, very well. Okay, let's move to next question, question number 3. Okay, next question mentions the features corresponding to inattention in ADHD include. Again, just a different way to ask the question. Please read the responses and answer it. What are the features that correspond to this type of hyperactivity in ADHD? Option number A, often fidgets with hand and feet, that we have already discussed, that yes, they always have that kind of distractive movements in the body, especially shivering of the hands and kind of fidgeting with the legs and the hands. So that is again correlated with what we discussed. Often leave seat in classroom or in other situations. So they cannot actually sit for a particular duration of time, focus on something. So they keep fidgeting around here and there and distracting other people as well. Okay, next option is often runs about, in which it is inappropriate. So again, is trying to distract other people also. So that is also a very important characteristic feature that we have before exam. If we are trying not to focus on something, if we don't feel like revising all the units, and if our roommate is sitting very, very sincerely and has finished revising 3 and 4 units back to back, we don't want him to read further. We tend to disturb them. We try to play music or do some activities that he also gets distracted. So you don't want to study, and you don't want others also not to sit down quietly and study. So it again correlates with the pre-exam situation. Next option is often has difficulty playing in leisure activities quietly. So we have discussed that whenever there is an option to play around, that is to have some kind of chilling time, nobody refuses for that. So that is not a feature of ADHD. Whenever they have to do something which is very easy to perform, they love to do those things. But all those tasks which require sitting for a long duration of time, using their attention span, so they will try to refuse doing such activities. Is often on the go mode or often acts as if driven by a motor. So on the go mode is they are very, very impulsive to answer or to do any task. So similarly, when an MCQ pops on our screen during the exam time and we just read the topic, that yes, it is from tetralogy of fallow, we don't read the further question, that what the question demands from us. We tend to miss on small little things. We just try to read the option about TOF. Yes, this is right, so I'll answer ABC. No, we never have to do that. You have to always have patience, which is lacking in ADHD. So on the go mode basically means they want to finish the task as soon as possible without using their mental effort to arrive at what is demanded from the question or what is actually demanded from the task. Difficulty in sustaining attention in tasks or to play activities. Yes, that is very right. They cannot sustain their attention span in any important task. And often talks excessively. That is a very classical feature of ADHD. They are always going to talk too much. They are very, very talkative. So that also happens before the exam. We tend to talk too much. We become very anxious. We try to discuss things with our friends. We try to revise the topics. And those who are studying very quietly, revising all the units back to back, we tend to disturb them also so that they also don't revise anything and perform good in the exam. So these are all natural instincts that we have before the exam. So ADHD, you can easily correlate with that type of anxiety that we develop pre-exam. Okay. So let's move to next question, question number 4. So what is the medical management of ADHD? Please try to type in your responses. Very, very important question. Too many drugs are used for ADHD, but what are the names of these drugs? Please answer, everyone. Do we use methylphenidate? Yes, we use it. Okay, Nitya has answered A, B. Shiva has answered A, B, C. Yes, methylphenidate, amphetamine, atomoxetine are absolutely right. But to some extent, we also use antidepressants and antipsychotics also in severe cases. Okay, so we can use all of them, but the main drugs that we use is methylphenidate and also amphetamine and atomoxetine. These are the three important drugs, but we can also use antidepressants and antipsychotics in severe cases of ADHD. But hydralazine has got nothing to do with behavioral management of ADHD. So basically, it's a combination of medical treatment and behavioral therapy that can help a child to overcome ADHD. Is it clear to all of you? Please put the thumbs up those who have understood ADHD. All right. Okay, let's move to next topic now. Down syndrome. Very commonly asked question, 100% guaranteed question from Down syndrome in your exam in one way or the other. So this time I will not put down any guesses, any kind of clues to answer. All of you have to answer correctly because this topic is so important that all of you should know it by heart. So I'll just read out the question. I expect the right answers to come from you. So first question is, what is Down syndrome? Trisomy 21, delayed cognitive development, most commonly due to maternal non-disjunction, increased risk with advancing maternal age, always has got severe mental retardation. A, B, C, okay. Isn't option number D correct? Okay, Nitya has answered right. A, B, C, D. Trisomy 21, very commonly asked question. So Down syndrome is trisomy 21. It is caused due to maternal non-disjunction that happens. It is associated with increased maternal age at the time of conception, and it results into delayed cognition, but it does not cause absolute mental retardation in all children. Okay, so that is very, very correct. Next, move to next question for Down syndrome. Question number 2. Question number 2 for Down syndrome. The clinical features of Down syndrome are? Next question for Down syndrome. The clinical feature for Down syndrome are? So very important, head to toe examination of Down syndrome. I expect all of you have learned it by heart till now. So out of these important features, what are the right options for clinical features of Down syndrome? Please put down your responses. Okay, A, B, C, E, F. So short, hard palate, very right. They have got a short mouth because of which they have feeding difficulty. Flat nasal bridge is absolutely correct. Okay. Protruding out tongue and open mouth, very, very correct. Macrocephaly is not a feature. Instead, microcephaly is a feature in Down syndrome. Do they have small dysplastic ears? Yes, they can have small dysplastic ears. And delayed fontanelle closure. Delayed fontanelle closure is also an important feature. So A, B, C, E, and F, all of them are correct except macrocephaly, which is not present in Down syndrome. So very good, Shiva, Nitya, and Preeti, all of you have answered it right. So next question, question number 3. So question number 3 asks you, screening of Down syndrome is done in the first trimester with which of the following? Very important question, all of you should know. First trimester screening and then the second trimester screening. So question number 3, what is the answer? A and B. Okay, any more responses? So knuckle translucency thickness is a very important indicator for Down syndrome. It is done in first trimester screening on ultrasound. Maternal beta HCG levels are also very, very important, but we also have PAPPA levels, that is Papa A levels, that is also an indicator for Down syndrome in the first trimester. So there are 2 blood tests that needs to be done, known as dual marker, and there is one important NT-NB scan that is done in the first trimester. So knuckle translucency and the nasal bone. So NT-NB scan, which is done, is also an indicator for any kind of trisomies which can develop. So A, B, and C, all of these are the right options. Okay. All right. Next question, question number 4. So next question asks you, triple test of Down syndrome includes which of the following? Ultra important question, very, very repeatedly asked in your exam. Dual marker and the triple marker, that is done. So what are the components of a triple test in Down syndrome? Very good, Nitya. It's option number A. That is beta HCG, unconjugated estriol, and alpha fetoprotein. So I just remembered BUA. So BUA is the triple marker that is done in Down syndrome. So beta HCG, unconjugated estriol, and alpha fetoprotein. These three are the very important markers that is done. All right. So Papa A is done in first trimester, whereas in the second trimester, we have these three components which are important markers for Down syndrome. All right, next question for Down syndrome. Last question for Down syndrome is, management of Down syndrome includes what? Now, again, it's a trisomy and a genetic disorder. So we cannot completely reverse it back, but how we can manage a Down syndrome case? A, B, C, D, okay. So multidisciplinary approach is obviously the best answer to give for any genetic disorder, because we can have complications from any field. It could be ophthal, it could be ENT complications, cardiac problems, neuro problems. So that is one answer that is always right in genetic diseases. Counseling, very important, so that further whenever the mother tries to conceive again, knows the risk factor for Down syndrome, starts to take the medications earlier, and definitely is aware further for future pregnancies. Education and intervention is again very, very important. So any kind of interventions that is required for any birth defects, and early initiation of these important interventions. So it can result into various anomalies later on. So we should know all the complications that can happen and how to manage them. Physiotherapy is again very important, because they can have neurological problems. Occupational therapy is also the right answer. So occupational therapy is also very, very important. So in genetic disorders, mostly OT and PT, that is occupational therapy and physiotherapy, go hand in hand. So usually most of these disorders require both OT and PT. So all of them are correct answers. So the answer for this is A, B, C, D, and E. All options are correct. Okay. Is it clear to all of you about Down syndrome? Any doubts anybody has, please ask in the chat box, or we can discuss in the end of the session also. Can we move to the next topic? Okay, thumbs up from you. Thank you. Okay, so next important topic here is microcephaly. Microcephaly is also very ignored topic, because we think it is not a separate topic in pediatrics, but it is very, very important. Here you have to mug up a lot of facts in microcephaly, but again, if you try to do word associations and certain mnemonics, which I've already discussed in my class, then you can easily memorize it. So first question for microcephaly. What are the primary causes of microcephaly? In which disorders do we usually see microcephaly? Down syndrome, Edwards syndrome, Patau syndrome, holoprosencephaly, and lissencephaly. What is the answer for this? Please type in your responses. So what is the answer to this question? Anybody would like to answer? So microcephaly basically means a small sized head. So all the responses, okay, Shiva has answered it right, A, B, and C. So all the disorders which are associated with trisomies usually have microcephaly. So Down syndrome, Edwards syndrome, and Patau syndrome, all of these three are classically known to cause microcephaly. Holoprosencephaly is a big sized head. It will fall under the category of macrocephaly. Lissencephaly is a neuronal migration defect, which might not result into microcephaly. It can definitely cause mental retardation, or to some extent macrocephaly. So A, B, C, these are absolutely right. Okay. So next question, question number 2. The next question mentions about microcephaly. Question number 2. Any doubts anybody has, please keep posting in the chat box. So question number 2 for microcephaly mentions about which syndromes are associated with microcephaly. So what are the important syndromes associated with microcephaly? Okay, huge list of syndromes that we need to memorize for microcephaly. So please remember them very, very well. Any guesses by anyone for question number 2? Or if you know which one causes macrocephaly, you can use exclusion criteria also to answer this question. Option number C, okay, Angelman syndrome does cause microcephaly. Any other disorder which can result into microcephaly? Okay, so please try to remember it very, very well. So we have all the disorders mentioned in this list which can cause microcephaly except Fragile X syndrome. So Fragile X syndrome does not cause microcephaly. It can have a normal sized head or it can have macrocephaly also. So Fragile X syndrome is not in the list of microcephaly. Apart from that, De-Lange syndrome, Aicardi syndrome, Angelman syndrome, Fanconi's, Prader-Willi, Bloom syndrome, and Cry-Duchat syndrome. All of them are classical examples of microcephaly. So these are some things which you have to remember by heart because they can be asked in the exams. The causes of microcephaly and macrocephaly, the syndromes which are related to these two important differentials are very, very important. Okay. So let's move to next question, question number 3. So what are the secondary causes of microcephaly? All except. Please read the question carefully. Secondary causes of microcephaly could be all except. So apart from primary causes, which are during the time of development, there are other causes which can result into microcephaly, that are the secondary causes. So which is not going to result into microcephaly? Head injury. See, head injury, if it happens, it can result into lack of development of the size of the head. So it can definitely cause microcephaly. So torch infection is well known to cause microcephaly. So out of torch infection, toxoplasmosis might not result, but CMV infection, rubella infection can cause microcephaly. Okay, fetal alcohol syndrome is again well known to cause microcephaly. When the child is in utero and the mother is having alcohol intake, it can cause microcephaly. Hyperthyroidism does not cause microcephaly. It has a normal sized head, whereas hypothyroidism can result into micro or macrocephaly, but it can also have a normal sized head. So hyperthyroidism can never alter the size of the head. Maternal phenylketonuria, again very, very classical example for microcephaly. Perinatal asphyxia, if the child develops HIE or perinatal asphyxia at the time of delivery, there can be restrictions towards the head growth causing microcephaly. Herpes simplex and meningitis. If the child has severe CNS infections, it can again result into maldevelopment of the brain, therefore causing microcephaly. Head injury can also result into improper development of the brain if it happens early in the age. So it can cause microcephaly because the sutures and the overriding of the sutures can result into improper head size. So all of these are causes of microcephaly, secondary causes except hyperthyroidism. Is it clear to all of you? Let's move to next question from microcephaly. Question number 4. So pathophysiology of microcephaly can be understood as. So what basically could happen in microcephaly? Please use your common sense. I think this kind of questions are not given exactly in words in the book. But if you know what is microcephaly, you can use your common sense and answer it. So what is the answer to question number 4? Okay, option number A and C. So let us read it. So microcephaly, we all know it's small sized head. So the first option mentions that it is the result of small brain and poorly growing skull. Very correct. If the brain size is overall small and the skull is not growing out properly, it can result into microcephaly. Abnormal neuronal migration that happens during fetal development. So if all the brain cells do not migrate properly, if the gray matter and white matter is not formed properly, it can result into small sized head. So again, option number B is also right. Okay. Option number C, cytoarchitectural derangement. So if the architect of the brain or the head size is not formed properly, if it is deranged, it can again result into a small sized head. Fourth option is Heterotopia of neuronal cells. If the neuronal cells again do not develop properly, it can result into improper development of the matter of the brain. So that is why it can result into small sized head. So all options A, B, C and D are correct. But deletion of the genes in chromosome 11. If chromosome 11 was the only cause that could result into microcephaly, we would have by heartily remembered the name of the syndrome. So chromosome 11 is nothing to do with this type of disorder. So all the options A, B, C and D are correct. Last option has been just been given to confuse you. There is no syndrome which is classically known to be causing microcephaly due to problems in chromosome number 11. Okay. So these kind of questions can also come in the exam where you don't read the exact piece of the text in the book, but then you have to exercise your brain and try to arrive at the right answer. So that is about question number 4. So let's move to next question, question number 5. So what could be the common investigations to be done in microcephaly? How can we investigate about the causes of microcephaly? So if we know the important causes, we can easily order the investigation. So please put down your responses. Anybody would like to answer this? Okay, Shiva has answered it absolutely right. A, B, C, D, E, and F. So Western blot has nothing to do with this disease. So serological test for torch infection, obviously. Torch infection we need to rule out. Chromosomal analysis, again for important genetic disorders and trisomies. Neonatal screening test, again very, very important to look for metabolic disorders. CSF analysis to rule out meningitis. Skull X-ray, CT, MRI, very, very diagnostic to rule out all the neurological disorders which can result into microcephaly. The improper structures that are there, neuronal migration defects, all of them can be picked up. Genetic studies, very important again to rule out the rare genetic syndromes, which the name of which we have just memorized. So genetic studies can also help us to diagnose the causes for microcephaly. Western blot is not useful in microcephaly because it does not cause the microcephaly. The tests are usually done to rule out infections. So Western blot test is not going to result into the diagnostic value for microcephaly. Okay, is it clear to all of you? Question number 5. So please put a thumbs up those who understood microcephaly. I'm very sure you must have not read it in detail till now because we tend to ignore such topics. But it is very, very important to touch each and every important topic from which questions are being asked repeatedly in exam. Okay. All right, let's move to the next segment for today's discussion, severe acute malnutrition. So general pediatrics, most important part of your pediatrics, which you cannot tend to miss, which you cannot overlook. So SAM is a golden topic in pediatrics and for your MCQs also. So first question for SAM. So what is basically severe acute malnutrition? Very, very important to know the definition by heart. No mistakes can be done in this. Please put down your responses. How do we define SAM? Anybody who would like to answer? Okay. Okay, B, D, and E, A, B, C, D, E, F. All right, let us see. So basically the classical definition for SAM is weight for height or length. Most of the time we get confused the weight for age or height for age. It is nothing to do with age because SAM is usually age-free criteria. We have street children in our country. Many times it happens that adopted child or a street child is brought for evaluation in the hospital and the child seems to be very, very malnourished. If we don't know the age of the child, how can we calculate whether the child falls under SAM criteria or not? So that is why in SAM nothing is to do with the age of the child for criteria. It is weight for the length. So what is the height of the child and what is the weight for that particular height? If that criteria is less than 70% or less than equal to 3 standard deviations, both of them are right, A and B, then we call the child to be severely acute malnourished. Okay. If there is visible severe wasting on the child's body, you see loose folds of skin hanging from here and there, baggy pant kind of appearance, monkey facies, loss of the buccal pad of fat. So severe wasting seen on the body of the child is again very, very important criteria. Bilateral pedal edema. So bipedal edema is again a classical feature of SAM which actually depicts the loss of protein in the body. which happens in a type of SAM known as kwashiorkor. So again, it is very important to look for pedal edema in the child. Again, age-free criteria, mid-upper arm circumference. So if you measure the mid-upper arm circumference of the baby, if it is less than 11.5 centimeter, then it is a criteria for severe acute malnutrition. So that is very, very important to know the exact cutoff for severe acute malnutrition in our country. Children between the age of 3 to 12 months can be affected. No, that is not the case. It starts from 6 months of age and we can assess up till 5 years for children of SAM. So this definition is valid from 6 months till 5 years of age for all the children, and they can be assessed for severe acute malnutrition. Is it clear? Let's move to next question. Question number 2. So next question for severe acute malnutrition asks you the indications which are important for inpatient care of severe acute malnutrition. So when you actually sit in an OPD and you see a severely acute malnourished child coming up to your OPD, coming up to you for evaluation, when will you advise admission to that particular child? So inpatient care is important when if there is a presence of medical complication. Question number 2, presence of any medical complication, reduced appetite, presence of bilateral pitting edema, if the age of the child is less than or equal to 6 months, or whether the child is having excessive crying spells. So when do you actually advise admission in a case of SAM? Can you guess this question? When will you tell a SAM baby to get admitted? A, B, C, D, that is absolutely right, Nitya. So whenever there's any medical complication like hypoglycemia, any kind of electrolyte disturbances, then we advise admission. Reduced appetite is very important because if the child is sent with reduced appetite back to home, they can further lose weight and the clinical condition can deteriorate. If there is bilateral pitting edema, which classically signifies hypoalbuminemia in the body, they might require further IV transfusions of albumin or blood products. So that is why we need to admit. If the age of the baby is less than or equal to 6 months, so less than 6 months, we are not able to assess the classical signs of severe acute malnutrition. So if the baby seems to have visible wasting on the body and the age is less than 6 months, then we need to admit. Please remember this criteria, the definitions for SAM which we have learned, the cutoff for SAM, that is valid from 6 months to 5 years of age. But SAM can be present as early as less than 6 months in our country because of practice of malnutrition. So whenever we see visible severe wasting and the weight of the child is very, very low and the age is less than or equal to 6 months, then we have to definitely admit the baby. So pitting edema and visible severe wasting, two criteria can be used to evaluate SAM in less than 6 months of age also. Excessive crying spell is not a criteria for SAM, so we don't need to admit such a case. So A, B, C, and D are right answers. All right, let's move to question number 3. Okay, very, very important. What are the classical features that we see in SAM? Very important. Those who have read this topic can easily answer. Classical signs from head to toe that we see in a patient of SAM. Please put down your responses. Do we see flag sign? What is flag sign? Yes, we do see flag sign. It is seen on the hair of the child where there is alternate textures of brown, black and white type of hair which looks like a flag. Okay, Preeti has answered A, B, C, D, E, G and F. All right. So all the options are right except option number C. We don't see hypertrophied papillae in a patient of SAM. There is ageographical tongue and there is loss of papillae that happens. So flag sign is right. Bite-out spots, very, very important because of vitamin A deficiency in the eyes. We can see bite-out spots. So all the micronutrients are deficient in a SAM child because they are malnourished. Hypertrophied papillae is not correct. We see atrophy or loss of papillae in the tongue of the baby. Moon-like face is very important because they have edema all over the body. Now, having a moon-like face, having a fat belly, having swelled up feet is not a classical sign which we see in SAM, that is malnutrition. But it is a classical sign in a subtype of SAM, which is known as kwashiorkor. So in kwashiorkor, there is edema all over the body because there is loss of albumin or protein from the body. We have another type of SAM, which is known as marasmus, which is more commonly seen in our country. So please don't get confused with marasmus, which looks like a monkey facies, loose baggy pant, or kind of appearance of loose folds of skin on the body. Marasmus is different, kwashiorkor is different, but both of them are severe acute malnutrition. Malnutrition does not always mean that the child has to look sick. The child can look very much swelled up also. So that swelling is not good because it is again a classical feature of SAM because of loss of protein from the body. So moon-like face is a very dangerous sign which is seen in SAM. Okay. Ichthyosis very classically seen. So at the angles of mouth, we can see the roughening of the skin and tearing apart of the skin, which happens because of vitamin B deficiency. Muscle wasting, very classical sign of marasmus, which is a type of SAM. Flanky paint dermatosis. So again, we can see the skin is tearing apart. So that happens because of edema that is present inside the body. So there is pitting edema, and there is going to be flanky paint dermatosis or skin involvement, which is seen in severe acute malnutrition. Is it clear to all of you? So please remember all the classical features from head to toe that is seen in a patient of SAM. Okay, next question for SAM. Management of PEM, protein energy malnutrition, which is a kind of SAM also, that is kwashiorkor, does not include which of the following? So please put down your response for question number 4. What is not done when a patient of SAM comes to you for treatment? Yes, very right. G, very commonly you can answer this question if you are in your senses. So we have to treat hypoglycemia, we have to treat hypothermia, we have to fix dehydration, we have to maintain the electrolyte balance. These are all initial steps that we do. We have to correct micronutrient deficiency. We have to supplement with all the doses of folic acid, zinc, copper, all the important micronutrients when the child starts to eat. We have to prepare and follow up for recovery. So follow up is very important. Many a times it happens that we work very hard for 2 weeks on a patient of SAM and we give all the good micronutrients. We try to gain weight in the baby. We try to feed the baby. And when the baby is sent back home, after 1 week, again, you see in the OPD, the same baby is coming with a monkey-like facies and you can't recognize. It's the same child which we treated with so much of hard work with weight gain, and now the child has again come back with a monkey-like facies. So follow-up and recovery is very important because we need to teach the mother how to take care of these babies at home. Many a times it happens that they don't take good care. They're not counseled properly about the diet of the baby or how much diet is to be given. So follow-up even after recovery is a very important component of SAM. Don't miss on that. Okay. Behavioral therapy, common sense, there's nothing to do with the behavior of a SAM baby. They are normal babies only. So behavioral therapy has no role in the management of SAM. It is to treat the electrolyte disturbances, fluid, RBS values, the temperature. These are the common things that we do for management of severe acute malnutrition. All right. So I think we come to the end of the session with this question. So I hope all of you have understood the important topics that we have discussed in these 3 sessions back to back in pediatrics. I think we have discussed around 18 to 20 topics. So please put a thumbs up those who have understood all the classes, those who have been attending regularly, and you have been able to understand the concepts related to these topics. Okay. Any doubts anybody has, please put in the chat box, or you can unmute yourself and ask the question. Any doubts anybody has? Okay, so thank you for listening to the class. Okay, thank you Nitya for your response. Thank you everybody for being so patient. You guys have answered very, very correctly. I'm quite impressed. Please go through all the lectures very nicely because most of the topics have been very nicely explained with the tricks to remember. Thank you Preeti. With the tricks to remember, with the mnemonics, with diagrams, with as much effort that could be done. Thank you Shiva. All of you have been very responsive in the class. So I hope that you will learn pediatrics very well and you'll score very well in this part of your exam. And good luck to all of you and thank you for listening to the class. All the best to all of you.